Welcome to episode number 3 of Inside the Loop. My name is Dr. Elbaridi. I'm an interventional pain medicine physician. And as every week, we try to enlighten you with having guests on our program who are informative, intelligent, and can contribute towards the topic of pain management. Pain management can be broad. People seek to us to provide them advice for possible interventions. And then, of course, something that what people commonly associate with pain management, which is medications. So today we have a pharmacist, Nima Matin, with us, who is going to talk about what does pharmacists do and what are the different types of pharmacists, and overall about his own perspective of pain management. Without further ado, Mr. Nima Matin.
Thank you, Dr. E. I appreciate it.
Pleasure.
Great to be here today.
So tell us a little bit about yourself. What kind of a degree do you have? And describe to us the path to becoming a pharmacist.
Absolutely. So I've been a pharmacist for the past 15 years, board certified in geriatrics. I've gone through pharmacy school at Fair State University in Michigan, and have been practicing ever since in different fields of retail, long-term care, work comp, consulting. Currently, I have my own business. I have a pharmacy consulting company that services long-term care facilities. We do medication regimen reviews for nursing homes, roughly about 350 homes we service in 15 states. And then I have another company that does work comp prescriptions and personal injury for anyone that was in a work comp case or personal injury accident. I've been with that since 2017 and running it ever since.
Wonderful. And take us through a typical day-to-day. Well, actually, let's take a step back. How did you stumble upon, why did you decide to go from retail pharmacy business, which is what people most commonly associate with being a pharmacist, to being your own boss, to kind of doing things on your own?
Absolutely. So the consulting side of long-term care is something I've always wanted to do ever since pharmacy school, just getting exposed to that. So eventually in 2012, I left the retail setting, worked at a long-term care pharmacy, and worked as a consultant for that pharmacy for about 10 years or so, till eventually an opportunity came around to start my own business. We began with servicing about 20 homes in Illinois in 2020, late 2020, and have just grown it since from there.
Mid-COVID, basically, you...
Yeah, absolutely.
There was Phoenix rose from ashes, huh?
Yeah, there was opportunity that came along. It was a very tough time for long-term care in general with COVID, but it's things are kind of finally getting back to where they were before.
What does a consulting pharmacist do exactly? Give us a little...
Yeah, there's a lot of different things. There's a regulatory aspect to make sure that the nursing home is complying with all the state and federal laws. And then they really provide a medication regimen review, evaluating a medication therapy for a resident to ensure that the drugs that they're on are safe. Any lab monitoring that needs to be done is being performed. If they're having any potential side effects from it or require dose reductions or anything like falls or weight losses, it's really all encompassing in terms of the scope that we look at.
Mm-hmm. And does this involve actually physically being on present and having a team of people, or just kind of looking at reviewing data records and things of that nature?
Yeah, so both. The reviews are done remotely. We also do admission reviews when they come to the facility. So we're constantly going into their EHR every 2 to 3 days to check and see if anyone needs to be reviewed. And then we do have a presence every month at the facility. We can attend QA meetings as part of the regulatory compliance, do unit inspections to make sure the med rooms are in standing order, be a part of GDR psychotropic meetings with psych providers. So there's a lot of different aspects that we can get involved in as well within the home.
Now, a lot of the times in my kind of business, we talk about what's called pharmacogenomics. Do you deal with that? And can you give us a little understanding of what exactly is pharmacogenomics?
Yeah, absolutely. So pharmacogenomics is the study of a person's genome to determine if there's alterations in the way that they metabolize drugs. Okay. So they might be rapid metabolizers or slow metabolizers of a specific metabolic pathway, and that can influence the side effect profile and also the effectiveness of a medication. So typically you'll do an oral cheek swab, and we do this for a lot of residents in the homes. And then you send that into a lab that analyzes the DNA, and based on the genetic material can determine which pathways they might be varying in metabolic in their metabolism.
So that essentially, if I understand this correctly, in the context that you're using, that increases the safety for the patients and actually increases the efficiency and the efficacy of the drug that is being prescribed, correct?
Yeah, absolutely. There's probably some 600 drugs, I believe, that have some kind of genetic implication in the metabolism of them. And many of these are commonly used drugs. A lot of the pain medications, for example, can be more or less effective and have worsening side effects like sedation and falls. So especially in the elderly who are sensitive to those medications, we definitely want to look. And even for an average healthy adult, they might be a rapid metabolizer of a certain pain medication. So it just might not work for them.
I see. So when it comes to elderly patients specifically, I know that um, age changes the way that the body processes medications. And with your specialty in geriatrics, that kind of lends itself to you being the expert and being in the position that you are, that you oversee the delivery of healthcare, makes you essentially an integral part of someone's loved one, someone's well-being, if I understand it correctly.
Absolutely. Older adults especially can have physiological changes that can affect their kidney and liver function and how they metabolize and process drugs. So medications can very oftentimes accumulate in their body and make them more susceptible to adverse effects. They can also be dealing with just polypharmacy, where they take more medications than your regular person does. And these can all interact and cause compounding side effects, again, like sedation, falls, and things that are concerning. And then also, elderly adults can be just more frail or have cognitive deficits that can increase the potential for like confusion, altered mental status, and it falls as well. So these are all very, very important things to look at.
And does the system that you use, does it feed into some sort of a central drug monitoring system?
We do have in Illinois what's called the Illinois Prescription Drug Monitoring Program, and we utilize that a lot, especially for diversion to make sure people aren't going to. But oftentimes, patients just won't know that something that they're taking from their doctor for something else could interact with something that a different doctor gave them. So we monitor that. We run it typically on a monthly basis when we dispense anything, and it shows us the pattern of any narcotics or controlled substances.
I digressing just for a second, in my own practice and in most interventional pain medicine practice, the utilization of prescription monitoring programs has become a norm, more basically a standard of care. I recall many years ago when I finished my fellowship, or while we were in fellowship, this was at its inception. I trained in Boston, and we have organized the entire state to allow us to have understanding of other prescribers who are within our cohort network at the Mass General at Brigham Network. So I saw over the years, as other states have joined the initiative, that the connectedness between all the states has improved, but it's still not perfect. The federal system really, in my opinion, needs to have one standard guideline like PMP that connects all of the states so that a practitioner who practices in Illinois, just like I do, can see somebody who's coming from the state lines. And too often I actually have to have pauses in my practice because when I check the prescription monitoring program of a person who came from Wisconsin to see me, or from Indiana or even Missouri, I have to take time to call these states independently because there's a lot of time that there is the lack of connectedness. How do you overcome that when patients in nursing homes in long-term facilities transfer from one state to the other?
Yeah, it's very important to try and be a good historian and get as much information as you can from the provider, especially if the patient or the resident doesn't know. but that certainly is challenges that because the DEA should, I think, really should take over that and do it on a federal level. It would make things a lot easier.
I really have high hopes for AI. In today's day and age, I've seen tremendous aspect of synthesis of a lot of even my own notes, and I foresee that in a not too distant future, we will actually have the ability to not only synthesize the information which comes from PMP, but from things such as WellPoint or other EMR, electronic medical record connecting databases between big names like Epic and Cerner and Athena, with the information data sharing really is indispensable.
Absolutely. That's a big struggle that we have in the nursing home, especially is a lot of time residents are readmitted coming in and out of the hospital and they just don't share information. And oftentimes they'll come and changes will happen at the nursing home and then they go back to the hospital and they don't know. They just kind of put them back on what they were before. And then they go back to the home with the wrong medications now. And the nurses don't know that the hospital made a mistake. So that's going to be crucial, I think, is getting everything linked up to.
I asked you at the beginning of the conversation what exactly is consulting when it comes to pharmacies, and now I think that you've delivered us an answer that is very complete.
Yeah,
So,
absolutely. There's a lot of ways a good consultant pharmacist can help a nursing home.
and I can always see that the trajectory of you graduating from pharmacy school and then going and working in retail, understanding that aspect of what people see as a front for all the pharmaceutical care, when in fact that is sort of like prepared you to be a good liaison and connect with nursing homes and be on the forefront of being able to actually deliver really a good medical care.
Yeah, absolutely.
So, in this context of delivering medications in a safe manner to nursing facilities, to long-term care facilities, there's this other avenue we practice that deals with management of medications to patients who have been injured through other types of instances, such as job-related things or car accidents, commonly just referred to as workers' compensation or personal injury. Tell us a little bit about that part of your business.
Yeah, absolutely. So I got into this in 2017 with some friends that were attorneys that wanted to partner with a pharmacist. So we started this company and in Oak Brook Terrace. Basically, over time, they all kind of stepped away because their practice changed. So it's just me kind of running it solo, and it's a very useful service that we provide to patients who've been in these kinds of situations.
That's why. I mean, a lot of people don't have a good understanding
Yeah.
of this concept of work comp pharmacy. And part of the reason I'm asking you this is because there's a lot of misconceptions about patients who have been injured in car accidents and workers' compensation, because most people just, understand that there is a financial remuneration for seeing patients in that category.
Yeah. So the way that this really helps patients is if they get a prescription from their doctor that's related to this work injury or personal injury, and they go to the pharmacy will typically just bill their regular insurance, and any copays or deductible are going to be their responsibility to pay. And what we do is we specifically bill the work comp carrier, or if it's a personal injury case, issue a lien to the attorney and get compensation that way. So there's no upfront charges to the patient. And even if the case is denied or and the claims don't go through, we don't bill the patient. We just kind of absorb those costs. And what we do is we call the patient when we get the prescription, gather all their information and their history, and then let them know that we're going to be sending the prescriptions overnight via FedEx. So it's a very convenient process for them to just kind of receive the medications the next day at their doorstep.
I see. Okay, so you offer kind of like a mail delivery.
Absolutely.
Okay, that's very convenient.
Very much, yeah.
And what type of prescriptions do patients typically get? Obviously, different providers have different ideas about how patients should be treated. In my practice, I've heard a lot of providers, for example, refer to compounding of medications, meaning creating generic medications that are not on regular formulas in pharmacy. Do you do that kind of stuff? Or
So we don't. The work comp rules have kind of changed where compounding was very big and very profitable, but a lot of the insurance carriers kind of stop reimbursing on those claims. So we just give standard medications, no compounds.
I see. Um, this is a great question. What kind of providers typically work in your setting? In other words, with whom do you normally associate yourself with?
Yeah, so the big ones would be like you, pain specialists, because they're seeing a lot of people who've been injured on the job or in these accidents, and also orthopedics who are performing surgeries sometimes and asking for medications either post or prior to surgery. So those would kind of be the two big ones. Every now and then we'll get some from primary care, but they don't really understand about these work comp pharmacies and just send stuff to the regular.
But if they want to find more, we'll leave a link in our bio in the context of this podcast, so that in case primary care providers, whoever is watching us, or even patients who have been injured in accidents, can reach out to Nima and his pharmacy group. How do you approach? I guess a different type of question. The medications that you prescribe, are these medications that are brand name? Are they generic? And give us a little bit of understanding of what exactly is the difference between generic and then brand name medications.
Yeah. So most of what we do is generic, and occasionally we will get brand name meds, which are just newer meds that are on patent still. The generic alternative is pretty much the same ingredient as the brand name medication. There might be some different inactive ingredients in it, but the active compound is the same.
So they work as intended, right?
Yeah,
And who regulates all that? I mean, can you just kind of make up out of your mind, or
yeah, no.
is there like a cookbook that you look into and say, this can be a generic? Give us a little bit of knowledge about that.
Absolutely. So the FDA regulates all of that. Essentially, when the drug goes off patent, it's got a limited number of years. It's the market becomes open to generic manufacturers, and they have to submit a proper approval to get to be approved with the manufacturing process and to show that they are equivalent and all of that.
You see. And in your pharmacy, you have a leg up on all of this because you keep up with not only regulatory environment, but the way that I envisioned and I understood what you as a consultant do is you really are in both instances of workers' compensation and managing nursing homes. You're providing a generic, lower cost medications, which are beneficial for the patient and also beneficial for the people who are paying for all that.
Absolutely. Cost containment, especially in the nursing home, is a big thing that we do to make sure that not only you're using the most cost-effective medication within a category, but also that there aren't unnecessary drugs that you're prescribing. So deprescribing as well, that's very important.
I think for the most part, we have answered all the questions that I wanted to ask. While we're on the subject, and because you're the pharmacist, and I get often asked about, in today's world, about medications that are unregulated. So if you have been living under a rock in the United States, you probably have not heard of TRT replacement, and you have not probably heard of peptides. First of all, does your pharmacy offer either one of these two medications?
We do not, but I'm very familiar with the whole peptides and TRT as well. It's a very interesting field of medicine now that's becoming more popular, I think.
Yes.
But it's like the Wild West when it comes to it, very unregulated and
Yes.
not sure what you're getting.
I'm saying this because there is definitely a merit of, for example, GLP-1 medications, which have been popularized over the last several years, that are being prescribed for weight loss. And more we learn about these medications that now have significant amount of data that they work when they're prescribed in proper way, when patients are being properly monitored with proper dosages, that they not only provide what their initial intent is, but they also actually have a significant impact on addiction because they downregulate the dopamine centers in our body. And I believe that there will be a lot more evidence coming about treatment of alcoholism, treatment of addiction in general, and then even treatment of smoking. But one of the things that concerns me as a physician is unregulated prescription of peptides. And, a lot of the times, even today, I've got a text from a good friend of mine who basically says, "Hey, can you prescribe me peptides, or can you get peptides for me?" And of course, when you're in a physician's role, we have access to various manufacturers, people who are at times inundating us with offering these compounds. And I have grave reservations about medications that are labeled as peptides because, as you said, they're completely unregulated. We don't have any safety data. We don't have any dosage recommendations that have been standardized, that have been proven. We don't understand the longitudinal effects of these medications. So if peptide industry skyrocketed, let's say 2 or 3 years ago, we really have no clue what will happen if somebody takes compound A, B, or C. I'm sure you've heard of TB500 or BPC157, GH, and so forth. And then the most important aspect about this is that, sometimes we like what FDA has to tell us, and other times we don't. But FDA has really no opinion that has been publicly shared with a lot of the people who are getting these medications from places like China, Mexico, and other countries to whom we really don't know the process of sterility of the compounds, of actually compound ingredients that are being mass marketed and injected to all patients.
Yeah, absolutely concerning from a patient standpoint that you don't really know who's making this under what conditions, and it's something that you're injecting into your body. So it's can be a little nerve-wracking, I think, at least for me, not having that information.
Yeah. No, I think that down the road in next few years, we will see some deleterious effects of this unregulated industry, which, it may work, but we just don't know at this point yet.
Yeah.
Well, I'm glad that you are on the right side of the history at this point, that you're kind of holding courses and not advocating for that. So that's a good thing.
Yeah, absolutely. There's a whole other side of it too with testosterone replacement and growth hormones, where those are manufactured, but they're using it for maybe things that it's not intended to be used for as well.
Exactly.
You just got to be very cautious.
And TRT has been proven to be effective for people who have either hypogonadism or people who have low testosterone, or in aging population with multiple other indications. But for all those things, rather than going to an online source, my advice has always been come and see a physician. I'm perhaps not the best person to prescribe because I'm an interventional pain medicine physician. It doesn't mean that I don't know how, but I would always divert prescription to a colleague of mine, such as a primary care doctor or an endocrinologist, who kind of deals with these things on a more regular basis.
Absolutely. And I think a lot of people reaching for these, if your testosterone level comes back low at 200 or so and you want it to boost it, sometimes changing your lifestyle, your diet, your sleep, exercising, these can all have a dramatic effects in raising your testosterone versus just going and grabbing some exogenous form that you can just inject.
Absolutely correct. I could not agree with that more. I've seen somebody talking about all these medications they were talking, and then completely disregarding the aspect of nutrition and proper exercise, sleep, which, hyper-regulates all of our functions.
Absolutely. But I do think it's important to run at a certain level. You don't want to be low. It can definitely.
Well, what questions do you have for me? I mean, is there anything that you perhaps have for me that you're not familiar with, or?
Yeah, I guess just understanding your practice and what kinds of patients you see and cases you deal with. Is it a lot of surgery, a lot of just like pharmacotherapy that you're prescribing, or what your goals are?
Great. We try to have a broad approach, what's called a multimodal pain management, which is, why I think that speaking to you specifically as a pharmacist is very important. I have a great respect. You touched upon something about, PMP, but, a more human approach is a collaborative effort of pharmacists. In instances, for example, when I have prescribed medication and I get a call from a pharmacist who literally sometimes says, "Doctor, are you sure you want to do this?" And that is a, to some big ego physician that may seem like an offensive thing, but I always welcome when a pharmacist reaches out and double checks and offers an extra layer of security. But specifically, my practice, I approach treatment of pain management through number one, the most important aspect, which is evaluation, and that does not mean looking at a computer. That means talking to a patient, evaluating them through methods of physical measures, range of motion, whatnot, reviewing the medication history, and then ordering appropriate imaging, an imaging that can be either through X-ray or imaging that can be through an MRI, CT scan, ultrasound exams, and whatnot, and then offering the right kind of treatment. To some, treatment may consist of literally just conversation. If somebody's anxious, like we had a patient, for example, today who was complaining of chest pain when she was sitting, normal 23-year-old female, and she had two prior emergency room visits within the last week, and she came with completely negative workup. And when she was in my office, I had a hard time of just gathering her to quiet down her mind and then offering her what my piece of advice was, which was that she suffers from an anxiety, which was giving her this perception of chest pain. And then to treat an anxiety, obviously there are agents, pharmacologic agents, and then we also have interventional procedures that are complementing sometimes, depending on the patient's physical structure. So in my practice, we see patients of all ages. We generally don't see pediatric patients because that seems to be a little bit more of a specialized field. But patients that have, like we discussed, been injured in an accident due to work or an accident such as a slip and fall, but also, patients who are lifelong athletes, patients who are aging athletes like myself, who have had, a lifetime worth of abuse on their body, if you will, and are now feeling aches and pains of early arthritic changes or maybe pinched nerves and things of that nature. So I love what I do. I think that there is definitely a void and an access to the physicians. And why we're successful is because we have allowed our patients to find us through not only our website presence, but also through social media presence, and then podcasts such as this, where we invite them to come and get evaluated in a much quicker time that, for example, a patient who is in pain could generate a visit at a big hospital system. And myself and providers that are in similar shoes like me have a much shorter lag to from a phone call or from a text which is made to our clinic to patients being evaluated and hopefully helped.
Yeah, that's wonderful because nobody wants to deal with that stuff for a while, and
Sure.
it's a great service that you provide.
And it plays a role into this paradigm that we're touching upon, which is prescription of opiates and pain management medications. In the past, the old way of providing pain management was truly through opioid prescriptions, and the expectation of a lot of people has been, even public sometimes, to basically almost divert all the opioid prescribing to pain physicians, where in fact we are probably on the forefront of guarding that uh, aspect of patients getting indoctrinated into a medication that could harm them. I think that United States is probably one of the only countries in the world where you can walk into a physician's office and obtain an opiate prescription. If you try to do it in Europe, there's no way. You cannot go into a doctor's office and say, I need a hydrocodone, oxycodone, or whatever that medication is. They'll basically say, these are scheduled medications. You have to go to hospital for that.
Yeah, I mean, it's some of the last data I think I read was that the U.S. population is 5% of the world's population, but we consume 90% of the world's hydrocodone. So definitely, I think we look at pain with a different perspective out here.
Sure.
Not that it's always inappropriate, and it is good to have access to pain management because you don't want anyone to suffer. Um, but sometimes it's doing other therapies, like you said, and just looking at other.
Absolutely, yeah. And that's basically what your question asked a moment ago, this whole aspect of multimodal pain management is exactly that. Don't rely on medications. Focus your recovery through management of nutrition, management of sleep, physical movement, physical motion, which is done through initial physical therapy, chiropractic visits, and also through some of these small interventions that we do in an effort to kind of move the patient along the recovery.
Yeah, that's exactly what I think people need now.
Awesome. Well, today is Cinco de Mayo, and I think that we and our wonderful crew who is taping this interview need to go and celebrate. So
Yeah, it was a pleasure. Thank you for having me.
thank you. Good luck, and if anybody needs to get hold of consulting services, you know where to find us.